Welcome back. I have the honor of introducing our next speakers. Each will discuss a particular aspect of gastrointestinal issues. Both are experts in their field. In fact, they are physicians that work directly with patients. They're also researchers who are using what they know and what they learn in the clinic to push the understanding of the link between GI problems and neurodevelopmental disorders forward. The first two speakers are going to focus on the links between the brain and the GI system, commonly referred to as the gut. First, I'd like to introduce Dr. Jimenez-Gomez from Joe DiMaggio Children's Hospital in Florida. Dr. Jimenez-Gomez is a neurologist who deals more so with the brain and not the gut, but he cares for children with neurological and behavioral issues as well as neurogenetic conditions. As a physician, Dr. Jimenez-Gomez works with patients every day to help manage real problems experienced by those with NDDs, also gastrointestinal issues. He's here to give the opening talk about GI issues and other comorbidities in neurodevelopmental disorders. Thank you, Dr. Jimenez-Gomez. You're welcome to share your screen.
Thank you for the invitation. Let me pull up my screen over here. I'm not sure if you're able to see it. All right. Is it visible to y'all?
Yep.
All right. Well, thank you for the invitation once again. I'm Andres Jimenez-Gomez. I'm a pediatric neurologist and neurodevelopmental disabilities specialist, and certainly I deal for the most part with children with autism, some into adulthood already, as well as other folks with neurodevelopmental disabilities and other neurogenetic conditions, and certainly the overlap that we are to share in this meeting. I unfortunately or fortunately no disclosures to share. But I wanted to give a little bit of a different focus to some of the information that we're going to share today, because of course there's going to be a certain degree of overlap with some of the things that so many brighter minds than I in the world of GI issues and whatnot are going to share. So I wanted to kind of give a sense of what the developmental process is for children and individuals with neurodevelopmental disabilities and how that is affected and how that impacts the actual process of living conditions that we see every day. So I think of this as a sequence of A to B to C, which is, you know, there's a starting point in everything, a number of causes and risk factors that in turn lead to some of those changes in the brain structure, just as they do in any other neurologic or neural structure, the enteric nervous system, the gut nervous system, so to speak, but also how it impacts the brain structure in turn to impact the developmental patterns in individuals. We all hear about development of, you know, gross motor skills like walking and running, as well as fine motor skills or visual motor skills like the use of your hands, the nonverbal learning abilities, or speech, and several other components in that. And those changes are going to lead to different symptoms and behaviors, whether we're talking about symptoms that are pure and reliably measurable. In my case, for example, epilepsy. In the case of our GI experts, diarrhea or constipation and whatnot, or the behaviors that we all see very often in children that may be an impact of some of those symptoms, such as irritability, aggression, or other changes in development as well. And this is based essentially on that collection of changes and how those changes manifest what we typically deal with, which are clinical diagnoses. That means the collection of symptoms. You can see from this slide that there is a wealth of etiological factors or risk factors, so to speak, that I think is the basis of a lot of the research that we do have. We have a lot of information about the genetic impact that can change the brain development, the metabolic changes, infectious exposures, a number of other things that we've seen over time and studied. And we have a wealth of the information down at the bottom resulting from that, what's called the developmental brain dysfunction, about all of those manifestations from autism to intellectual disability to developmental delays to seizures. But what's a little bit less known at times is the interaction between those and certainly the environmental influences that affect the severity of each one of those. So how can development in a child be affected? there's essentially three layers that are probably the big tenets of how we in neurodevelopmental disabilities tend to approach development. There's certainly delayed development, which is what we commonly would think of, let's say, a 3-year-old doing the things that a 1-year-old ought to be doing. There's going to be immature traits, and those immature traits are going to reflect on the child's social, behavioral development. That means how they interact with folks, how they behave around play or other circumstances, just as much as their temperamental and emotional development. So are they tantruming at 4, as you would kind of think of as a 2-year-old with their terrible twos, so to speak? You can also see discrepant development, which would be really a difference between each one of those trajectories. Let's say a difference between the fine motor development and the language development. And the way I like to think of that is kind of thinking of an out of sync video, so to speak. If your visual abilities are much superior to your audiological abilities, if we were doing this meeting and you would see me talk, but you wouldn't be able to hear me until a few seconds later, it would be very hard to bring that sensory information together and take action on that sensory information. We could certainly turn the the computer screen off, but in the case of something that's happening continually, you're going to start to have altered sensory integration, and you're going to start to have atypical traits as a response of this. So not so much immature, but atypical social, emotional, and behavioral traits. And that gets even more accentuated when we think of disorganized development. That would be when a child's developmental pattern is not following the trajectory that you would wish or expect. That means you are achieving, for example, skills like reading before you're able to put 2 words together and whatnot. And those, in that inability to comprehend, for example, that functionally that reading aspect of that visual perception that leads to reading, means the brain is not understanding what sensory information it is going to take and how it's going to process it and take it in and use it functionally, and leads to further and further atypical traits in those 3 spheres of development. And what
Dr. Jimenez-Gomez, I'm sorry to interrupt you. You may want to change your settings to the display mode, because we can see what you're seeing right now. You just go to the switch screen.
Switch screen. Oh my goodness.
Display settings, I think, up high.
Oops. This over here?
There, you got it. All right.
I apologize. Okay. So what this boils down to essentially is those changes that we are all quite familiar with in terms of what the impact is in those social, emotional, and behavioral spheres. So you have changes in the interaction with other folks, the verbal and nonverbal interactions with gestures and whatnot, withdrawal, the reciprocity, the eye contact, and the aspects that we're all very familiar with in regards mostly to children with autism, but across the spectrum of developmental disabilities. You have emotional and temperamental changes in children that go anywhere from irritability to aggression, as well as changes, as I mentioned, in play, in the what's called the Dunn model of sensory perception, which are these sensory seeking or sensory aversive and very active or passive kind of profiles. So as I mentioned before, we know a lot about how this plays out in certain conditions, in certain genetic and well-described genetic conditions. I lay out a few examples of some that have increasing or pre-existing research, such as SYNGAP or SHANK3, which is Phelan-McDermid, or Angelman syndrome, which we've known for many years, or Rett syndrome as well. And we know certainly how those, to an extent, change the structure of the brain. We know SYNGAP and SHANK3, for example, are very linked to the way the neurons, the cells of the brain connect with one another. And we know there's some growing research into some of what Dr. Bennett had mentioned about sensory processing and sensory integration as an interplay there. And we certainly, again, know those symptoms and behaviors, but what we don't have a better understanding of it is how that environmental impact affects some of those and how these experiences are accentuated experiences of what any other child could be going through. And this is certainly, just an emphasis on that circuitry that you're going to hear more about from other folks, but this gut-brain axis has a role not only in the brain, not only in the way the brain links to the gut, but in the way the gut itself will structure itself around the neurotransmitters, or let's say hormones that affect its function, and that in turn affect the brain's function and affect the immune regulation within the gut, and a number of other features that are, the topic probably of many other lectures or talks today. And we know that there is growing aspects in different areas of research. I'm not going to emphasize on much of this myself. But we know that a lot of these issues are a different degree of effect of some of the conditions that affect children, no matter what the developmental trajectory. I mean, a lot of us who have children who are, as they would say, neurotypical, or who don't have a neurodevelopmental disability, are familiar with a lot of the food refusal that you would see when a child turns 2, 3, or 4, and they know to say no. We also see a lot of behavioral regression in things like toilet training when it comes to having a new sibling or moving to a new city. Those are expected and anticipated behavioral reactions. Or a lot of children who cannot allow their food to touch on a plate. And this seems somewhat odd and extravagant when we think about it in children with neurodevelopmental disabilities, but on reflecting, this happens to children across the neurotypical and neuroatypical spectrum. It's more about how those symptoms display themselves in the children with neurodevelopmental disabilities that we see in clinic that really play such a significant role. And I don't think that it's worth emphasizing on the wealth of symptoms that are typical and often found in children with neurodevelopmental disabilities. In my perspective, I see a lot of children who have repetitive behaviors, severe tantrums, who have sensory seeking behaviors just as much as sensory aversive behaviors. They like touch, they dislike touch, they like visual stimulation, they dislike loud sounds. There's a wealth of symptoms, and certainly the focus on some of the symptoms today is how I as well tend to go about some of the gut and the GI related issues that I see in our children. Maybe my colleagues on the GI floor are going to disagree a little bit on my approach, which may be oversimplified, but I think of the GI symptoms when I confront them in clinic as one of 4 layers, and I try to understand each one of those individually. So a lot of the intake related difficulties is what we commonly see of food refusal or non-edible intake, for example. The children who I see that are often eating rocks or biting or eating erasers. We know for a fact, and I think that there's a very interesting talk coming up, that in certain genetic conditions, there's a lot of aerophagia, or a lot of swallowing of air that in itself turns into from that neurodevelopmental into behavioral into a GI issue, which feeds back into the behavioral difficulties. There's a lot of swallow-related difficulties, and certainly there's a lot of oral motor difficulties in certain neurodevelopmental disabilities, but in this context, it has a lot to do with that sensory perception. A lot of our children with autism, for example, have a lot of gagging and choking, but also very often vomiting and regurgitation. A lot of transit related, which is the focus a little bit of some of the research that I've been fortunate to share with some of the other speakers today, which has to do with motility and ultimately with pain, bloating, and reflux, as mentioned. And aspects related to stooling, which again is often a feature in neurotypical individuals just as much as neurodivergent or neuroatypical individuals, ranging from constipation to diarrhea. Really the cause and the why and what process may have led to it is what varies off. So what is known certainly is the data that has to do with some of the studies, certainly not what Dr. Bennett, of course, just presented, but some of the studies that are available across the board insofar as GI symptoms. And what we certainly know, you see a study on the left, which is from Duke University, and a study on the right, which is from the University of Missouri, about 170 something individuals on the left and a little over 340 on the right, but essentially telling us a little bit about that same continuum and those very prevalent symptoms across the lifespan. Constipation being the major one, as Dr. Bennett had brought up in the Candid GI study or survey, and certainly something that persists over time, but a wealth of other symptoms present there. We know even further, this is an interesting overview of some of those functional GI difficulties that individuals across the lifespan face, very similar and even projecting further in time from what Dr. Bennett had mentioned of how many individuals are affected with things anywhere from ages 1 to ages 52 years of age. This is a study specifically from Spain, bringing about that association. But of course, you're going to hear more about that. My point of interest is how that associates with the behavioral and neurodevelopmental features of the children that I get to see every day, and how those symptoms that they are brought to me for may be the expression of GI discomfort in any capacity. So we know there's a few studies that tell us a lot about the sensory seeking and sensory aversive behaviors and changes to the actual sensory, what I call sensory outlets, so some of that aggressive and repetitive behaviors. That is present and that has been broadly observed in different studies and in different settings in children. That goes across the board into those repetitive behaviors and into those self-injurious behaviors, as much as aggression and other aspects of irritability. What I think is interesting in some of these, and I'm sorry, I would say, and there's perhaps as what Dr. Bennett was mentioning, kind of that progression into adulthood and better communication, you might see symptoms that are less externalizing, less of that aggressive, self-injurious behavior, and more internalizing behaviors in the youth, in older children with autism, particularly in this case. But what's interesting to me is that from this particular systematic review, you see that there's a lot of contradictory evidence, and particularly a lot of contradictory evidence surrounding changes to development proper. There's a lot of behavioral changes, and there's a lot of behavioral changes surrounding sensory processing, sensory integration, sensory aversion, sensory seeking behaviors and whatnot. But the aspects that have to do with, for example, language and communication only have contradictory evidence. And that's probably due to some of the limitations. I think that part of us, as the big emphasis by Dr. Bennett was, some of the limitations of how we are measuring and how we are seeing some of these features. And I think of 4 major limitations that I often find as a clinical challenge in my practice. One, I think it doesn't warrant re-emphasizing to any better extent than what Dr. Bennett has already disclosed. We don't necessarily have the appropriate tools either for every, let's say, genetic or neurogenetic condition, or for every child with a neurodevelopmental disability in one individual clinical profile. This, Dr. Bennett also pointed out, is that ethnocentric research that we have. A lot of what we have, unfortunately, comes out of populations in the United States, and certainly the participation tends to be very different across ethnic backgrounds and racial backgrounds. I work a lot overseas in South America, and I work a lot in Florida with Latin American populations, and the dietary components the components of our diet may vary much and may vary a whole lot more if you go across the globe. We also have that massive, for lack of a better word, heterogeneity in what neurodevelopmental disabilities and autism often mean as a clinical diagnosis, but what represents the background to that clinical diagnosis, whether it's a genetic risk factor or genetic cause that has a clear link, and therefore a clear link, for example, such as SHANK3, the Thielen-McDermott commentary that we had before, with gut motility, with low tone, or what are we basing some of these studies on? It's very different to have an individual who was diagnosed, for example, with autism at age 14 after relatively subtle symptoms than to have an individual who is 2 years of age and they've been nonverbal and has epilepsy and has a number of other factors that impact how we could reliably measure and study and bring together those individuals to give us information that is valuable and applicable. And certainly there's, I think, a lot of noise, a lot of individual experiences, a lot of anecdotal experience, a lot of information that is of, let's say, unclear reliability about certain diets or dietary fads for individuals selling certain things and offering easy solutions when it's easier to take a quick response and something that appears to display results, and it tends to lead to a certain bias. And I would say, of course, not limited to that genetic information, but very pertinent to how we are studying a lot of the aspects that have to do with autism, neurodevelopment, neurobehavior, and neurogenetics. Is we are delving deeper into the specifics of why and trying to understand how that one specific condition, as from its cause, and the environmental impact and the environmental experiences that we all go through, delivers into some of those GI symptoms. So here it's just an illustrative example of different genetic and neurodevelopmental conditions that we know have some reliable evidence of changes that have to do with GI symptoms, and a certain genetic condition that may produce neurodevelopmental disabilities, just as it may produce other difficulties in development of any other organ system as well. So, in conclusion, it's a lot of the experiences that the children that I get to see are a reflection of experiences that any child may have, but the impact may be affected by the neurodevelopmental trajectory, the genetic aspects of what caused the neurodevelopmental trajectory in and of itself, and how those genetic aspects and some other aspects of not only brain formation, but general organ and neurological or nervous system formation may impact the symptoms, and reciprocally how those symptoms impact behaviors. Thank you.
Thank you, Dr. Jimenez-Gomez. It was an excellent broad picture as we start hearing from all of the gastroenterologists to understand the topic from a neurologist point of view and the comorbidities of the patients that you see. I'd now like to introduce Dr. Kent Williams. Dr. Williams comes from another side of the issue, as he is a pediatric gastroenterologist at Nationwide Children's Hospital in Ohio. He is part of the Autism Treatment Network and now goes by Autism Care Network, the Gastroenterology Committee, and has been on work groups to establish guidelines and recommendations for treatment of GI issues and those with neurodevelopmental disorders. He is a perfect match for Dr. Jimenez-Gomez. And like our previous speaker, he works directly with families who have neurodevelopmental disorders in an effort to provide them with the best care possible. He will be talking about dysmotility of the GI system and how it influences behavior. Dr. Williams.
All right, finally found the button there. All right. Thank you very much for giving me an opportunity to speak, and very honored to be talking on the other end of things after our neurologist here. But I'll be talking about the brain gut issues that we deal with every day in our autism GI clinic here at Nationwide Children's in Columbus, Ohio. I have no financial disclosures, but one disclosure I do have: this is definitely a GI talk, so there will be a lot of talk about poop. As we've already talked about, constipation is one of the most common and one of the most troubling that we see in this patient population. The educational objectives, I'm going to go over I'll go over some just the most recent data we had. We're starting to put together kind of a database of patients been seen in our outpatient GI clinic of what the most common GI disorders are in children with autism spectrum disorders that have been referred to our GI clinic. This is going to be the diagnosis that were actually given by a GI doctor, and not just what the complaints and the referrals were, which is a little bit different than what other studies have looked at. We're looking at how the brain-gut interactions seem to predispose the children with autism for GI disorders. This is true not only for kids on the spectrum, though. This is true for kids with all types of neurodevelopmental orders. There is a high association of constipation, not only with kids with Phelan-McDermid that we talked about earlier, and with autism, but also just even ADHD, OCD, oppositional defiant behaviors, all kinds of neurodevelopmental disorders are associated with GI disorders. But what's interesting in this group is not only does the brain gut affect the GI function and development, but it also really affects how we treat or are unable to treat. So looking at our clinic over the last 12 years, our outpatient GI clinic, we pulled the charts just in the last couple of weeks. We started putting this together. This is very dirty data, but it kind of illustrates what we see all the time in various ways I've pulled this data. We got data from over 3,700 patients, and basically 60% of them were constipation, that they were diagnosed with constipation at some point in time by their GI doctor through their visits, whether it be the first visit or the second or third visit. Then you have to, it's 3 to 4 times higher than anything else. Constipation is by far the most common. But what was really interesting looking at this too, when you take a look at this, is all the other symptoms of the most of the top 10 are primarily symptom diagnoses, meaning that you make the diagnosis based upon the symptoms. You maybe run tests, do things, but you're not finding necessarily a physiological or organic cause on a test, but you are seeing that there tends to be things based upon symptoms, which would really go to the fact that it's primarily a functional or a brain-gut interaction that's occurring. So the majority of the symptoms that we see in these kids are due to brain-gut interactions. Now, I'll just focus on the constipation because that's one that we spend our most time on. Plus, it's the one I really see that really causes a lot of revisits and a lot of problems and constipation in the families. The one thing for sure is that, as Dr. Jimenez was talking about earlier, was that there is a lot of interplay between the behavior and the gut, and then the gut feeds back into the behavior. We see a lot of behavioral issues associated with kids who have GI disorders, particularly constipation. They may have a lot more self-harm behaviors. They have a lot more anxiety, a lot more meltdowns and things. But we also see that once we treat those behaviors get better. But sometimes if those behaviors get worse, the constipation, where there's a very much of a bidirectional feed between these conditions that we see. But more importantly, as Dr. Bennett was talking about earlier with his own experience, these children are very expensive. Common things such as constipation leads to a lot more doctor visits, increased ED visits. But not only that, but once they come to the emergency department, if they're having severe pain or fecal impaction, they are more likely than a non-autistic child or a neurotypical child to be admitted to the hospital for these conditions. And then also the chronic condition themselves can lead to physiological changes. It's not uncommon to get kids into the clinic who've had constipation for 5, 10 years. And then when we start doing imaging studies, it's similar to what you're seeing here, which is a single image from a contrast enema, which basically shows the pelvis that is completely filled with stool. But not only that, but the stool ball goes all the way up through the abdomen, up to the diaphragm, practically up to the chest. This is not that uncommon in these situations. And in fact, really one of the first GI papers published on kids with autism was a paper that had in the title megarectum, that over time, the chronic constipation will lead to a very much of a dilation. And then that in time will lead to non-functioning motility in that segment of the colon, which I'll talk about a little bit more here in a second. So what are the potential causes of the GI disorders? Most of what we see, as I said earlier, appear to be functional, but you do have to also consider, are there organic causes? And there's not really a lot of great studies done out there right now of trying to figure out which ones are organic, which ones primarily are functional, what leads you to think more organic. But we have started looking at, in motility, what kids who present to us with constipation and neurodevelopmental disorders, how many of them actually have a uniformed motility disorder, or do they have basically prolonged functional constipation and at one time maybe just had a normal functioning colon, or do they still have a normal functioning colon? There are evidence out there in animal studies that would lead you to think that there could be pan motility issues, particularly two studies. One was a mouse study and a zebra study. The mouse study was from a Pitt Hopkins mouse model where they had delayed upper gastrointestinal function, where you have a lot of reflux. Like 30% of the patients with Pitt Hopkins will have reflux, and about 75% will have constipation. The animal study showed that there was definitely a delay in gastric emptying and then delay in the transit in the colon. In Shank-3 mouse, zebrafish mouse model, or I'm sorry, in Shank-3 zebrafish model, they showed that there was a decreased rate of the peristaltic contractions of moving things along. So these genes could be associated with a pan motility disorder, but how does that translate into what we see in our clinic? Recently, we've just submitted a paper with a joint collaboration between us and the Motility Center at Cincinnati Children's Hospital Medical Center, that we combined all our children who'd been evaluated for motility disorder in kids with autism and constipation. And then we used a database that Cincinnati had to come up with a matched cohort. We looked at 35 kids with autism, 35 kids without autism. And what a manometry study is, for those who don't know, is basically you place a catheter into the colon. And that's what this is with all these leads here and these pressure sensors. And what it does is it will measure the pressure changes and actually show you the muscle contractions that are going on within the colon. And here is a representation of that these changes in colors are contractions that are starting proximally and going distally through the colon. Now, a typical person would have a contraction that starts and just have these kind of like repetitive contractions that would start proximally and go distally pretty much to the sigmoid and rectal area. People who have abnormal would have a different pattern and maybe not have any contractions at all. And what we found was when we compared between our autistic group and our control group is that the amount of kids who had completely normal function was the same pretty much in both groups, and those that had abnormal were the same also. So this leads us to believe that there may not necessarily be a different autistic motility pattern, but there definitely are some who will have some abnormalities. But the majority of the kids, when you have a normal functioning colon, means that most likely your constipation is due to functional constipation, which is primarily an issue of actually being able to get the stool out of the rectum. But when we look at our actual autistic kids, breaking it down even further, when we find that, again, 3/4 are normal studies, we have about 17, 18% that the problems with motility is in the distal colon, isolated in the distal colon. And if you remember that image I showed you a while ago, that's what it usually comes from, is that what we think happens is the kids have chronic constipation, that these children, this 18%, had chronic constipation that led to a stretching of the colon over time, and eventually becomes so stretched and so dilated that it can't function well, and it's not able to move the stool through well that section. Now, there was a couple of kids, and this is fairly typical. What we see in our motility centers is that there are a few kids that come, that they'll have complete abnormalities throughout the whole colon that we are able to study. So there are some that do, but the majority is most likely due to functional constipation. And as I was saying a while ago, the functional constipation is more from a lack of being able to get the stool out. Some people like to use the term stool withholding, but it's more than just stool withholding. There's definitely kids who definitely clench and tighten and try to keep the stool in, particularly if they've had large, hard stools. It's almost like they develop PTSD. But the other thing we see a lot of in some of the kids that we've tested here is that they have what's called pelvic floor dysnergia. And basically that is, you have a lack of coordination of the muscles. You have to be able to coordinate quite a few muscles to be able to control your bowels and to pass stool out. And what happens is the kids, you need to be able to tighten some muscles and relax others. And what we find is they'll tighten all their muscles at the same time, including the anal sphincter. And it just basically becomes one tight system that's pushing against itself. uncoordinated, and they're not able to get the stools out. The interesting thing is, through the years of working this, I've been doing this now for about 20 years, working with kids on the spectrum, is that the longer you work with it, the more you realize that the neurodevelopmental comorbidities and issues that these kids have tend to be more predisposed to GI problems. The restrictive behaviors, the oppositional behaviors, the obsessive compulsive behaviors, those things, they are highly associated with constipation and with GI issues. You don't even have to have the diagnosis of autism. Even if you just have OCD or oppositional defiant, you're more likely to have constipation. The same with anxiety and sensory issues. There's definitely a lot of sensory issues within these kids. And so it makes it even harder if they start having sensory overload from painful bowel movements or large bowel movements, that they begin to become very anxious. And like I said, they develop like a PTSD. And then the other thing about autism is there's always been a look at serotonin, that it's one of the first biomarkers of autism. About 30% of the people will have increased serotonin. And serotonin is primarily from the gut. And we've known for years that serotonin is highly associated with functional GI disorders. And also too, the sensory processing, again, the connection with the brain is the reason I show this is that you have lots of sensory pathways, a lot of interaction between your brain and gut. But the thing I really want to impress people is this interaction, the constipation, people like to think of it's just pooping. And what's the big deal? But bowel control is a learned complex behavior. Not only do you have to recognize the sensations coming from the rectal area, which would be like changes in pressure, but those changes go up through the spinal cord. They not only go through the midbrain, but they go to the higher functioning areas of the brain. They go to the somatosensory areas where you sense the things. They go to your prefrontal areas where you actually make decisions on how you're going to act upon those. And if you have developmental issues that impair those areas, needless to say, you're going to have problems learning how to poop. The interesting thing about the brain-gut interactions, and particularly with constipation, if you ever worked in a clinic where you're treating kids with constipation, you'll notice a lot of the kids have sensory issues with their mouths and with their eating and feeding refusals. And if you work in a speech clinic or a eating clinic where kids are coming there with restrictive diets or not eating well, you'll find a lot of those kids have constipation. And there was a study done where they looked at over 4,800 kids, and they studied them at ages 2, 3, 4, and 6. And what they found at the ages 4 and 6, if you go back, that those who develop fussy eating are more likely to develop constipation later, and vice versa. If they develop constipation, they're more likely later to develop fussy eating. Now, there may be a bidirectional component between the two, but the thing that would explain more easily is the fact that the same sensory behavioral issues that lead into problems pooping lead into the problems eating and feeling the texture issues and things in the mouth and then with the swallowing. And so that there is very much a strong connection. Now, why is this important? Well, when we try to treat functional GI disorders, most of the time you're trying to give medications. And one of the telling things in it is that when we look in our GI autism clinic, we find that almost half our kids are not on Miralax. And it's not because we don't like Miralax. It's not because we think Miralax is causing evil things or anything like that. But one of the most common complaints I have from parents is that either one, they can't get their kid to take the Miralax. They can't fool them at all. I've had parents tell me they buy like 6 jugs of Gatorade. They take 1 jug, mix in the Miralax ahead of time, close up the bottle, put it back on the shelf. The kid comes down, they take it off as if it's a new drug. They pour it, kid takes 1 sip, refuses to drink. They go back, get another jug without Miralax, they pour it, guzzles it down. The kid's sensory issues very much play a problem in what we're able to treat. And I think that's also true on the other end of being able to regulate the bowel movements, because if they do take the Miralax, the next most common complaint is we can never seem to go from hard stools to just soft stools. It's either we keep going up on the Miralax and nothing but liquid blowouts is what happens. You have 1 cap, nothing happens. You give a cap and a half, nothing happens. By the time we get 2 caps, they're completely out of control. So a lot of the brain-gut interactions not only causes these conditions, but definitely impairs our ability to treat them. And so just quickly, I'll go over things that it's led to us is that we'll do a lot of biofeedback for our constipation kids, especially for the higher functioning ones. They'll work with our nurse practitioner who's been trained in this. And the other thing we do a lot of is we do a lot of anal Botox injections where we actually put we give Botox right into the anal sphincter. These two areas are actually these two treatments are actually getting at the issues that we see that are the outcomes of this interaction of brain-gut interactions, where the kids aren't able to sense when they need to go, or they can't adequately control things, or they're so heightened and anxious that they're not able to relax their anal sphincters well. But when these don't work, we'll move on. There have been a couple of kids that are so severe that we've actually had to go to colostomy. Very rare though. And then cecostomies are something that we do a lot of, where you actually put basically a tube into the cecum area. You either make a conduit that's with the appendix, or you can actually put like a feeding tube into the cecum, and you flush the colon every day. The problem with this, it still doesn't get really at the area of the anal sphincter, and the kids can still hold on to it. Plus, they've got to be able to sit on the toilet. Interestingly, the one thing that I find very interesting in the last year that we started doing a lot for our kids who failed medical therapy and are failed biofeedback or anal Botox injections, or are not able to do them, is we place just a simple G tube. And with that, more than one of our parents who've had this in the last year have said it's a game changer for them. We've done about 6 patients. Only one of them actually pulled it out. Everybody worries about the kids are going to pull it out, and actually he didn't pull it out. He had a line connected to it. It got wrapped around something. He ran, the line yanked, and the tube came out. They immediately put it back in. He was totally fine. But I think one of the things is not only are we able to give the medications, but we're able to give nutrition if we need to, which is not really much of a problem, but what I think is more important, giving water, keeping these kids hydrated. Because I think a lot of times the chronic hydration or dehydration, plays a lot in the behavioral issues and a lot with the brain-gut interactions. And what we have found that since we've been doing this and treated their constipation, giving them fluids, we've seen significant behavioral improvements in these kids. So again, the interaction back and forth between the gut and the brain and the developmental and the behaviors is that we're able to take care of the gut. It improves the behaviors. And once the behaviors are taken care of, the gut seems to improve too. So just a little brief overview of what we deal with in our clinic. And again, as a summary, the functional constipation is the primary cause of constipation in these kids, is what we see. Definitely because of the genetics involved, though. I think we need to be able to, as Dr. Bennett was talking about earlier, we think we need to get to motility doctors fairly quick sometimes with the kids, particularly when they're really failing therapies, because maybe some of these kids, it's a very small subset due to the genetics, could have a global motility disorder. But the big thing is most of the symptoms we deal with are brain-gut interactions. And not only do they cause the GI disorders, but they really do affect our medical therapies. And not only do we need to think about being able to better detect these conditions in these kids, but I think we also need to think about better ways of actually being able to diagnose them. I've had more than one family come to me, is that all my doctors ever told me to do is just give Miralax. And as you see, almost half our kids are not on Miralax. We use other medications, we use other therapies, and we have a pretty good success rate with the other ones. So thank you very much.
Great, thank you, doctors. We've got some questions. Let me just throw some out. What are the most common treatments for severe constipation, and for a case of megacolon, what is generally used?
Lots of, whatever works, whatever you can get the kid to take, and whatever will work. Medication-wise, I will use Miralax if the kids will take it. I don't want to come across as anti-Miralax, but most of the kids, like I said, there's a good portion of the kids that Miralax won't take it. But the other thing is, I think one thing we do differently at motility centers that are done than what's done at most like general GI practices, we use a lot of stimulants. So that stimulants would fall into 2 medications, Synacot and Docalax or Bisacodyl. Synacot comes in like the X-Lax, the chocolate squares. Also comes in a liquid form that you can mix in with other things. It comes in tablets also. Docalax, small little tablets. Sometimes I can get the kids to maybe swallow that with some applesauce, ice cream, pudding, whatever. But we use a lot of stimulants and we use them daily. Whereas a lot of times at other places, even when I was early in my training, we were told, no, only use it 2-3 times a week at most. But we use a lot of stimulants to give that extra push through those areas of megarectum. Plus, the other thing I think it does is it actually increases the transit, increases the pressure up against the anal sphincter. And I think it actually helps overcome the resistance of these kids to pass stool. So we do use softeners, but we rely heavily on stimulants at that point.
Is there harm to frequent daily use of suppositories? And is there a difference in the type of suppository?
Great question. The problem with a lot of our kids is trying to even do it safely, right? I mean, I've had parents try to use enemas to do a removal of fecal impaction, and they're trying to basically ram a enema in there, and they miss, and they cause a huge scratch and scar on the kid. So that's more of the danger than, say, reliance upon a daily enema itself. Because that sacostomy I talked about, basically, that is doing enemas every day, but you're doing it from the top down. There's not a lot of harm to doing enemas necessarily every day, other than my concerns would just be how comfortably are the kids doing it, how easily is it done, and those things. Now, that said, I definitely have kids. They know that if I do an enema, I feel good, and they'll help and assist and do their enema, so it's worth a while. The different enemas we use, the one I like the best is one that is the enema form of the Dopalex I talked about. It's bisacodyl. It's about 30 ml, so it's about 1 ounce. It's got bisacodyl in it. So it doesn't create a lot of absorption of things, and it really helps the bowels contract and get the stools out. That's the one I'd like to use the most if I can. I do get a little concerned about using, let's say, daily fleets, the phosphol soda ones, because that can cause, if you're absorbing that fluid into your gut and absorbing it into the bloodstream, that can cause different electrolyte abnormalities. So I tend to try to only use those a couple of times a week at most. And I tend to warn parents, like, try to make sure that's being evacuated fairly soon. It's just not staying in the intestine and being absorbed. But those are the two enemas that I do a lot of. And then there are just suppositories, glycerin suppositories, Pedialax. That's a good one too. That one can be used every day also, because we use glycerin every day in our antigrade system. So it's okay to use it from below also. And then there is Dopalex suppositories that if the kids are able to withhold it. But the problem with the suppositories, like just a capsule suppository, is getting a kid to actually hold it in long enough for it to be absorbed.
Great. What are some of the common found causes of chronic diarrhea?
Constipation would be the top of the list if a kid came to me with developmental disorders. Next would be functional diarrhea, which would actually like toddler's diarrhea is what is another name of it. If the kids between ages 3 and 5, all these kids though that come to me, let's say they don't have constipation, I usually will screen them for infections. I've had a few times where, like, Giardia, chronic infection with Giardia has been found, and those things. Probably in our clinic, the most common one would be toddler's diarrhea, functional diarrhea. It's also called chronic non-specific diarrhea.
Okay. Is there any link between modified diets and severe constipation in neurodevelopmental disorders? Has anybody studied this?
So diet is a very interesting thing. What we found when we try to it's very hard to do because everybody's diet is so different. The symptoms are so varied. People have tried to look at this. There has been people always reporting like a gluten-free, casein-free helps with constipation and things like that. An interesting study that was done with that, where they did it blinded, they didn't see any difference. However, what they did notice was that when parents try to follow a gluten-free, casein-free diet, they tend to have a healthier diet. So they're eating more fruits and vegetables, or they're getting rid of a lot of processed foods and those things. So the interesting thing about diet is it's not the primary cause of the constipation, but if you're able to improve the general health of the diet, say with more fibers, more fluids, you're going to make constipation less likely and maybe more severe. But there hasn't been any studies really with any diet saying like it causes the constipation. And so far, it's really hard to do a study that's open label saying that this helps constipation. Any of the studies that have been blinded have not found an association between diet and constipation.
Let's see, how related is GI to urine retention and any solutions there? And this is something I've seen anecdotally in the PMS community.
Probably my second best referrals clinic is urology. Constipation is the #1 cause for urinary retention, urinary accidents, bedwetting, in kids who've been toilet trained. It's one of the, I don't know if it's the most common, but it's one of the most common. What happens is that, to go back to that picture I showed, I mean, I've actually had kids come to me. I had one young girl come to me once. Her belly was completely distended. She was coming to me for constipation. And yeah, she only pooped about once every 2 weeks. So I was thinking, like, this kid's completely impacted. Her distended belly looking like a big, medicine ball in it. It's all from stool. Turned out it was her bladder, that she did have a big stool ball. But the problem is that the anatomy is that the rectum presses up against the bladder, can actually obstruct the outlet of the bladder, so they can actually cause it not to want to empty, and then it causes overflow. So that once it's kind of like, the other thing is, if it doesn't cause a complete obstruction, is it gets so full that eventually it overflows and you have urinary accidents. So the first treatment for urinary accidents and things is to treat the constipation.
There's a few questions about Miralax, and I know there was some controversy about a study that came out, and then, it wasn't a great study. Can you just give us a recap on that?
I don't know about any studies coming out. There's been a lot of people claiming that Miralax causes neurological issues, behavioral issues, and things like that. We're actually here nationwide. I'm the only person I know that's actually looked for the toxins that are associated with Miralax, and there are small traces of toxins. So Miralax is a big polymer. It's polyethylene glycol, and it's based upon ethylene glycol. Now, ethylene glycol, single molecule of ethylene glycol, is toxic. But polyethylene glycol is not only used in Miralax, but it's used as a food additive. It's used in other additives with other medications. It's used in makeup. It's used in eye drops. It's everywhere. So when we went looking for ethylene glycol and diethylene glycol in kids on Miralax, what we actually found was there was no increased level between kids on Miralax and kids not on Miralax. In fact, it probably was sampling error, but what we found was we actually had a higher level of diethylene glycol in the kids not on Miralax. Then the other things we've done too here is we've done animal studies looking for neurological changes associated with high doses of Miralax and polyethylene glycol, and we didn't find it. So in my experience, 20 years of doing this, the side effects of not treating constipation is way significant more than any potential side effect from Miralax. And Miralax is one of our best stool softeners, so I wouldn't hesitate to use it, even in the very young. But with that being said, the one thing I teach my fellows and I teach our residents, Miralax is not the only one out there. If a family has an issue with Miralax, use a different laxative.
Great. Dr. Jimenez-Gomez, a lot of these neurodevelopmental disorders have a comorbidity of seizures and not sleeping, which involve a lot of medications, maybe medication cocktails. Are there related side effects affecting the GI tract there?
Certainly, there's a very broad variety of medications that we use for seizures, and oftentimes they have very different mechanisms of action, and it really is tailored to the individual type of seizures that children may have, or the symptoms that children may have. So we use things, for example, clonidine or glomphosine, some medications that tend to, let's say, make the child, soothe the child or soothe the individual a little bit. Sometimes we use antipsychotic medications and whatnot, but it really is very individualized to the medication and the context in which it is used. I mean, certainly there are some anti-seizure medications that have constipation as a side effect. There may be some that some parents report that it is all the contrary, that they have had diarrhea or they have had more frequent bowel movements, even to the point of incontinence sometimes, and it may even seem sometimes paradoxical. Now, we are using, let's say, more medications from our perspective, and in part also from the parent-guided, let's say, management with supplements and whatnot, in which you see an inherent impact in gut function. So, for example, a lot of children, whether for behavior in a less prescribed manner or for intractable epilepsy in more of a prescribed manner, we're using derivatives of cannabidiol, which is cannabis essentially. So those have an impact in gut motility as such. Just as much as we're seeing, for example, a frequency and use of things like magnesium and magnesium supplements, which we know also have an impact in gut motility overall, and they serve as a laxative in some contexts of, some parents find a relief in, some of the behavioral symptoms, but they might find that it is linked to a relief in some of the GI symptoms, or they may find that it's independent and you've kind of switched one, let's say, situation for another. But it's certainly a very broad question, so to speak. So it's, I see a fair bit of it, but it's how frequently and with which medication, it really depends on what we're talking about individually.
Dr. Williams, as a follow-up, one of the topics and one of the working groups is education, and specifically of GI fellows and residents. Is there a disconnect between what the neurologists are having to prescribe and what the GI specialists are seeing, or is there an awareness?
You mean a disconnect that, like, the GI
of information? Sorry,
like they don't know,
right?
They don't know like what the side effects are potentially of the medications.
Correct.
I think that's true for most people. I'll be honest with you. I mean, even because Andre, I'd very much like to hear on this. A lot of times, the potential side effects are both. I mean, you look up the potential side effects. It could be constipation. It could be diarrhea. You have to worry about it in the individual person. And it's really tough to find out, I think, except sometimes there's a clear history. You start this medication, we were able to come off all our laxatives, and we're, having diarrhea, those kind of things, or they all of a sudden need it. So I think most of us look for the potential side effects. A true understanding of which ones do what, it may be a little bit difficult, but I do think we try to keep in mind that any medication that alters neuroactivity basically is going to potentially alter gut activity. So the way we look at it.
We actually had parents that said they didn't want to answer the surveys for this study that Dr. Bennett showed us the results for, because they weren't sure what the cause of the GI issues were, whether it was the syndrome or whether it was the medications. I see Heidi, which is my wrap it up card, so I will let her continue.
So we are going to now move into the final talks of the day. Thank you both to Dr. Williams and Dr. Jimenez-Gomez. If we did not answer questions from the chat, we apologize, but we will definitely take them into consideration and try to get some information back onto the website. We're now going to move to the next event on the hub, which is the spectrum of GI issues in neurodevelopmental disorders and their impacts. So please go ahead and click the session in your schedule in the platform to join us, and we'll see you there soon. And you guys can just, if you exit,